From its inception, the Synergy stent was designed for healing and to treat your most complex patients and lesions. The Synergy stent's unique coating is applied only to the abluminal or vessel side of the stent, allowing the luminal side to provide optimal healing. This coating consists of a bioabsorbable polymer that is 4 microns thick and is coupled with a market-leading everolimus drug, allowing for synchronous drug and polymer absorption. Coupled with the proven platinum chromium customized stent architecture, Synergy has one of the thinnest stent struts on the market at 74 microns. The abluminal drug and polymer coating suppresses neointimal growth and may promote more rapid endothelialization and earlier healing, in comparison to conformally coated permanent polymer drug-eluting stents, which have been associated with delayed endothelialization and healing. In addition, the permanent polymer remains on the stent indefinitely and has been associated with late adverse events, including stent thrombosis. With the Synergy stent, shortly after the drug is released at 3 months, the polymer is fully absorbed, allowing the vessel to heal and providing patients with the freedom from long-term polymer exposure, eliminating a source of persistent inflammation and potentially reducing the risk of late stent thrombosis. The Synergy stent is designed for early healing and freedom from long-term polymer exposure. Heal with confidence.
Hello, good afternoon, everyone. Very happy and great honor to join Hsic again. And this is my presentation. I think everyone has dreamed, then you will have a chance to have nightmare. And this is the nightmare. So the patients, actually it's a very rare situation. I think everyone heard about that contrast-induced cardiac arrest, but did you ever see it? So this is my patient. Patient was 86 years old. Patient had history of DM, hypertension, hyperlipidemia, gallstone, and some surgery before. The patient was admitted for inferior STEMI in cardiogenic shock. You can see the ECG of the patient. Definitely there were ST elevation over 2, 3, and AVF. And the patient's blood pressure was recorded. You can see the blood pressure was very low, 80 something. So maybe just a usual inferior STEMI. We go to do the angiogram. This was the left side angiogram. Left main ostium has some disease. The shirt was very tight, 90% stenosis. Osteo AD, 80% stenosis, mid AD critical, more than 90% stenosis. The patient was admitted for inferior STEMI, so definitely we go to use guiding to do the right side. And for this case, at that time, I already done more than 5,000 PCI, but at that time, I used many guide, AL, JL 3.5 EBU. I cannot engage the RSA while the patient is in inferior STEMI cardiogenic shock because it's a very old lady, small grandma, the anatomy was strange. I cannot engage and the patient is in shock. So in this sort of situation, what would you like to do? Because the body build is very small, I choose SAL and then try to engage the RSA, but still cannot engage. However, I get very close to the RSA, and then I do one contrast injection. And the contrast injection go to the left side, and the contrast injection go to the right side. And it's lucky that we can delineate the critical lesion over the proximal RSA. But after this injection, the patient developed PEA and cardiac arrest. Now, this was the Sydney. And can you see any movement of the heart? Completely no movement after the injection. And I wire this while the patient's on CPR. Actually, how did I wire it? Because my guiding never engaged and cannot engage. And during the CPR, actually I use this way. I hit the aortic wall and then reverse rewiring into the RSA during the CPR. I found that is a good way. My friend also tried this. Sometimes if you can't see the RSA, you can just touch the wall and then reverse back to wire the RSA. So we do the PCI during the Lucas. With the Lucas, continue compress, and my team helped to inject the adrenaline, everything. And then we put a short stand, our oxygen stand over here, and then finish the primary PCI. And of course, it's not an easy procedure. The patient already arrest, the heart do not move, and we have to intubate the patient. And of course, the patient will move, and while doing intubation, we lose, despite I already put a guide extension, but we still lose everything. Lose the wire, lose the guiding, lose everything. But we have finished the PCI, we have put one stand over here. So, and the CPR was successful. You can see the patient's heart is moving again, and blood pressure come back again. But we had not do the final angiogram. So, there's a question for you. After all this situation, will you do a final angiogram for this patient? At that time, we do the final angiogram again for the guiding. You can see that there's good news. We successfully opened the RSA. You see the blood flow from the RSA is better. It goes to the distal RSA. We found that here is a critical lesion. Here is some disease in the mid RSA, but the flow is improved from the proximal RSA to the distal RSA. The bad news is we inject the contrast, we do the angiogram, the contrast go into the left side and go into the right side again. That means it displays the blood from both left and right, and in this critical patient. And the patient arrests again. And you can see again, absolutely no movement on the heart anymore again. And then this time, it's lucky that we did record for you is the reverse wiring in the aorta. Hit the aortic wall and then we reverse rewire into the RSA. And then we have to do the PCI under the Lucas again. And finally, we finished stenting all the RSA, and the flow was improved. Despite some no flow, we had treated, but the patient still has very high ST elevation. So we guess the problem is the blood pressure is very low. With low perfusion pressure, there are not enough perfusion to the left side because the AD was also very critical. So we decided to PCI to the AD, just stand the mid AD, and then the flow improved in AD, and the ST elevation resolved. And it's a miracle. After that, the patient can move his hand and wake up, and patient actually survived, despite CPR arrest twice in the procedure. So it's a miracle. I think I still have some time, so I share another nightmare. It's a cardiac arrest caused by POP, bifurcation. Now, so never say it's a simple PCI before you finish it. We initially think this is a very simple bifurcation, and but it's not. And there's a very short distance from the bifurcation to the left main. Yes, whenever you encounter this situation, you need to be very careful. So we had do it with IVS guidance, finish the 2-cent bifurcation, and then with the classical teaching, we go with POP. Just POP, and then the patient's blood pressure drop. Gradually drop. So what happened? Actually, it's here. he found one hematoma over here. And remember the left main and the proximal, and the bifurcation is very short. Okay. And that is the situation. There's a hematoma form, dissection form at the osseo AD and extend. And then just 2.5 minutes later, just a few minutes later, the hematoma extend to the distal left main and also to the osseo shirt. And the osseo shirt become very tight, 99% stenosis. Oh, sorry. And also compromise the fold in LAD. You see the wire is in LAD. There's no fold in LAD anymore. The fold is the diagonal. And the shirt was compromised. We have to wire the shirt. And then I put the patient on stand. And after that, the patient's arrest. And we have to do CPR, and again, we lose the wire again. And after lose the wire, the situation, lose the wire insert, we have put one more stand. And we have P-dilated osseo shirt. There are probably some minor dissection in the osseo shirt. Luckily, we still have some wire in AD and with one balloon in AD. So how will you settle this situation? The fold in AD was gone. So actually, in this situation nowadays, very complex. Will you try to settle it by fast revascularization, or you try to fast put the patient on ECMO or impeller? So in this case, we try to use fast revascularization. We quickly use filter to wire the circumflex again, put one stent in the circumflex, and then crush. Probably that was my father's left main PCI, and put it in, and then restore the flow, and it's okay. This case is particularly unforgettable is because I checked the CK after the PCI, it's normal. No wise in CK, despite the patient had arrest and with such situation. So patient finally was rescued. It's okay. And this was my second nightmare in bifurcation PCI. Probably I still have some time, so it's lucky that I prepared the third case. It's a CTO case. Left side angiogram, everything is okay. But this CTO is very special. It's special in the sense that the blood supply in the left side is very strong. You can see from the angiogram, the coronary supply to the left side was very, very strong. And this was the angiogram from the right side. The right side blood supply is also strong. You see, it's unusual. The left side is strong, the right side is also strong. Very strong blood supply on both sides. I had tried to wire and then just P-dilate with a small balloon. I remember it's just 1-0 sapphire. And after that, the patient suddenly arrest. Just P-dilate with 1-0 sapphire. And then arrest. I don't know what happened. It's not perforation because I did not see any pericardial effusion or something. And even if pericardial effusion, it won't arrest so quickly. And we give IV adrenaline and then stand. But of course, very difficult to wire because during the cardiac arrest, the patient actually lose all the wire. And then we have to wire it again first with workhorse and then crusade and then workhorse again. And finally we wire the true lumen and then stand. And is okay after the stenting. There was no pericardial effusion. Up till now, I cannot explain what is the cause of the cardiac arrest. I'm thinking about, I have shown you the situation of full competition in CTO. In this CTO, the right side blood supply is very strong, the left side is also very strong. Maybe I just open it with a small balloon and I disturb the balance of the blood supply, so the antegrade fold and the retrograde fold, it compete each other, and then it caused this issue. I cannot be sure for that because it's not a recorded case. I cannot review unlike the previous case. So that's the end of my presentation. I show you some rare cause of arrest during the CAT lab in AMI, in bifurcation, and in CTO. So thank you very much.
Thank you very much for your very interesting presentation. And do the panelists have any comment for his presentation?
Okay. Hi, hello, Lam.
Hi.
Thank you for your sharing. I thought it was excellent, especially the first case of the anomalous right coronary. And you showcased the difficulty to wire it. And somehow you managed to make a big loop and managed to get the wire in. And I thought it was brilliant. Then I think when we have difficulty to re-engage the guide, but once we manage to wire, and especially in the case when you have already put a stent, one thing I have learned is when we inflate the balloon in the stent, sometimes we gently pull, sort of anchored the balloon in the stent, and then as you gently pull the balloon, the guide will suck in. Yes. Sometimes that works. But yes. I think you did a mother and child, right? You put in a catheter to get a proper injection, yes. But I thought it was brilliant. Thank you.
Just one question from me. Why do you think the injection causes the VF?
Yeah, because it happened for twice already. The first cardiac arrest, it happens after I do the contrast injection, after the coronary angiogram, and then the patient's arrest at once. And then I finish the PCI, finish the CPR, the patient wake up. When I do the final angiogram, I inject the final angiogram, and the patient arrests again.
Yeah, I know. What is the mechanism why it
arrests? I think most likely it's the displacement of the blood, because coronary angiogram itself, it will induce some ischemia, because once you inject the contrast, then the contrast will fill in the coronary and it will displace all the blood out. And in this very fragile, already cardiogenic shock case, when I inject the blood, the contrast go into left side and go to the right side, then it displaces all the blood in the heart, and then the patient's arrest. Probably that is the mechanism, but I'm not sure, of course.
The other mechanism I'm sort of thinking of is when they put the AL quite deep in, that it may cause severe AR. Yeah, sometimes the blood pressure may drop and causes hypoperfusion and causes arrest as well. So sometimes when you do the unplugs to do RCA CTO, when you try to very deeply engage, you suddenly see the blood pressure drop. Then you have to make sure that you have to lift out the AL guide. Then the pressure will come back to normal. So sometimes the AL guide may cause causes AR, and then blood pressure may drop. Now the other point about this anomalous, this is the right coming from the left coronary sinus. So I found it, if you go for femoral, radial is quite easy to engage actually. It's just for some reason quite easy to engage. But if for femoral, what I usually use is I use a longer JL, and then engage the left coronary, and then push it forward, and then it will just flip back into this anomalous artery.
Okay, thank you so much, Dr. Lam Ho, with a very challenging case. One more, Dr. Lam Ho. And I think PCI during cardiac arrest is very difficult, because we do PCI and with cooperation with the teamwork, cardiac pulmonary resuscitation. And in that time, wiring to the culprit lesion, as you present, very difficult. Sometimes you need guide extension catheter or so on. And the etiology, very variety. The first, contrast media anaphylaxis.
Xin thông báo,
The second, the
báo cáo viên
last
chỉ
balloon
còn 2 phút trình
with
bày.
POT.
Xin cảm ơn.
And the third is small balloon with the CTO. But I like, and every case is happy end. I like to ask you about how many percent you do PCI in cataract arrest successfully.
Arrest out of hospital and cardiac arrest inside the hospital, STEMI, there's another story. Out of hospital is around 50% survival. And for cardiac arrest, in hospital probably around 60%. I'm not sure about in hospital one.
Okay, thank you. It depends in hospital and out hospital cardiac arrest. Thank you so much. Excellent. And the next presentation, we would like to invite Dr. Wong.
How to open this one? Okay. Okay, so how to. Okay, so thank you for the invitation to present this case. So it's my nightmare and unforgettable challenging PCI case. So it's a 75-year-old man, hypertension and hyperlipidemia, and had a gastroesophageal junctional adenoma, cancer, and chemotherapy and some surgery done about 2 years ago, complicated by the anastomotic leak and residual adenocarcinoma in the adventitia fat. So not keen for further chemotherapy, so multiple admission for gastroenteritis with dehydration, hypovolemia, and distributive shock, and acute kidney failure. So I was admitted in May last year with fever, temperature of 38.8, and a bit of renal failure, and ProCal is 2.2, CRP is 112. So a bit of infection there. White cell count is 19, and he had a non-typhoidal salmonella bacteremia on the blood culture, so slightly secondary to gastrointestinal, given that have a recent diarrhea illnesses. So I had a blood culture done, and it was salmonella sensitive to ceftriaxone. So I had a CT scan done in May last year, and there was no evidence of, he had an aneurysm there, but there no evidence, previous aneurysm there, 3.7 and 3.3 centimeter, and stable infrarenal. It was diagnosed before, but there was no myocardial aneurysm, and also no evidence of leak or rupture. So if I can just show you the angiogram, I'm not sure whether I can stop where the aneurysm is. Here you go. Yeah, this is where the aneurysm is. It's going to run one more time. Yeah. So from the beginning. Yeah, it was measured 3.7 by 3.5. It's coming down to the heart. Here you go. Yeah. So this part there. Yeah. Okay. So it was stable on IV antibiotics and managed in the general ward in June. A few days, about 2-3 weeks after admission, he suddenly became hypotensive, blood pressure about 70 to 40, not responding to fluids, was brought to medical intensive care unit for inotrope support and in mechanical ventilation. The blood pressure, the MAP was already 45 to 50 on triple inotrope, and HP, the first sample measured after the event was 5.2, but repeat was 9.0. And the ultrasound showed, abdomen showed that there is no fluid in the hepatorenal and splenorenal angles, so there is no rupture of the aneurysm. So planned for CT iodogram when the patient was more stabilized, and bedside echo showed that he had a grossly normal LVEF. So this is an ECG done while the patient was unwell, and it showed that it's a grossly abnormal, multiple leads of acid depression and AVR elevation. So in view of the cardiogenic shock and triple inotropes and ECG suggestive left main occlusion, reviewed by our department, and cath lab was activated for this case. We consulted the cardiac thoracic surgeon regarding the infrarenal abdominal aneurysm. They said that IBP in this case is not contraindicated since there is no leak and the aneurysm was stable. It's a high-risk nature of the procedure was explained to the family, and the cath lab was activated, and it was early in the morning, about 3 a.m. So IBP, this right femoral artery access, 6 French, J wire was advanced under fluoroscopy because we know that there is an aneurysm there. It went out uneventfully. Yeah? So we did an angiogram. It's a left dominant system, and as you can see, there is a very tight LAD lesion, a bit hazy, so that is probably the culprit vessels. The right side is very small. So there's some distal disease in the Hsic, but not so severe. So mid-LAD was hazy, and there was some distal Hsic and LPDA lesions. So the plan was PCI to the LAD with the IBP support because on triple inotrope. So the next thing is how to select the IBP when the patient you know that have an infrarenal aneurysm. So the patient actually is 167 centimeter. So, but we consciously select a smaller size IBP because we don't want to have a IBP pulsation in the aneurysm, so it's smaller. So that could be a mistake, or could be, I'm not sure whether that's a right decision. Yeah, so we put an IBP on the, sorry, did I put an IBP? Yeah. So we, there's some slide which is missing. Anyway, so we put the IBP on the right side of the groin because we know that is in the correct, not cross the aneurysm already. So we puncture the left side for PCI. So this is wire gently going out. It sort of touches the aneurysm a bit, but I didn't push very hard. So eventually went out. So the PCI was not so complicated. It was pre-dilated, and we put a 225, 29, but we post-dilated to 2.5 and 275 with NC balloon. So the final result looks quite acceptable. So the procedure's finished. So, but we realized that actually the IBP actually now has moved down to the abdominal part. So we sort of reintroduced the IBP wire, and we could see that the wire actually make a loop around the abdominal area, but eventually we managed to put the wire across the arch and then push the IBP up there, and then this is where we ended. Yeah, so we stitched down the IBP catheter, the nurses stitching down. But the tip of the position was again migrated down towards the abdomen, but the position of the catheter in the groin never moved. So it means that the catheter has actually turned inside the sort of shortened inside the aorta. So again, I tried to push the wire up, and then push the IBP up. But the problem is this wire always go up to the top, to the like a carotid, to the subclavian or carotid artery. So I changed to another view to have a look, and this is what I saw. The wire was, I was panicking, where this wire gone to? Yeah. So I punctured the left, the femoral vein, and then push the wire up to check what this position is, and then it followed the same path as the inferior vena cava. and my IABP actually is in the inferior vena cava. So we did a contrast injection, and then they see the connection between the aneurysm and the inferior vena cava. So it was 3, 4 o'clock in the morning, so I closed my eyes and pinched myself. I thought that I had a bad dream and can't believe myself, so recheck again, and it's still in the same position. So, so we did a sort of picture to check a bit of better sort of visualization of the connection between the aneurysm and the aorta. So we have no choice. But IBP was never inflated in the IVC because it never reached that proper position. Surprisingly, the BP was very stable at that time. Yeah, 120 millimeter on triple inotrope. The vascular surgeon was called and reviewed the patient in the cath lab and decided to go for aortic stent graft in the OT. Then the surgeon took a long time to call out to get the proper size of aortic stent graft. While preparing for OT and stent graft, the BP gradually drifted down, and they had a PA collapse while he was transferring to the bed to go to the OT, and CPR were commenced, but unfortunately wasn't successful. So what actually happened? So I was thinking very hard what actually happened for this case. The first possibility is that during the last attempt to straighten the IBP wire actually traveled from the aneurysm into the IVC, and subsequently advancements of the IBP into the IVC. That means that the IBP wire actually perforated the aneurysm. So likely it's a mycotic aneurysm that make it soft so that the wire perforated it. Second possibility is when the IBP dropped down and curled inside the aneurysm, the backward and forward movement during the pulsation of the IBP actually perforated the aneurysm. But in this, it'd be unlikely because the pulsation of the IBP would have created a much bigger fistula and then causes certain hemodynamic collapse. Yeah. I think the last explanation is the most probable, that mycotic aneurysm actually has spontaneously ruptured when the patient deteriorated in the ward and causes the hypotension and then causes the cardiogenic shock. And while we try to rewire the last time the IPP wire, the IP wire actually just followed the track into the inferior vena cava. So could the complication be prevented? Is the indication of a PCI and IBP indicated in this case? I think it is, because very tight LAD lesion, acid depression, and the patient is in cardiogenic shock. Should I have selected a larger IBP catheter because it's shorter? So that's why it had opportunity to curl inside the aneurysm. So could have chosen a normal length IBP, which is 40 cc. And also the visualization of the IBP wire insertion should have used a proper angle to make sure that the IBP go up the aorta rather than go into the IVC. So the reported incidence of IBP-related aortic perforation in cardiac patient is about 0.2 to 0.5%, but may be underreported. The IBP perforation of the aorta is characterized by a sudden and rapid deterioration in the patient's cardiovascular status that allows no time for investigation. But in this case, it didn't happen. But actually, it makes the situation more stable a little bit. So maybe the IBP balloon actually seal off the fistula, so improve the hemodynamic slightly. Yeah. The diagnosis therefore require clinical awareness and index of suspicion and careful clinical observation. So this is the reported quite old study that the perforation related complication about 0.2 to 0.5%, and including dissection and perforation can be up to about 4%. Yeah, for the ILBP complication. So this is one of the case reported in the literature that you can see that this IBP actually perforate the aorta and then went into the mediastinum. But in this case, a covered stent was stent graft was implanted, and the patient was safe, but unfortunately not in our patient. So take-home message is IBP in cardiogenic shock has been downgraded in guidelines, but we as interventionists, we still use it for comfort in patients with cardiogenic shock. the IBP insertion increased risk of vascular complications. Yeah. So visualization of the guide wire and IBP implantation should be visualized under fluoroscopy, and extremely careful in patient with aneurysm if the patient is indicated for IBP. So for aortic perforation caused by IBP, usually the patient would deteriorate very suddenly, but treatment with stent graft could be used for life-saving. Okay, thank you.
Thank you for a very interesting case. Any comment from the panelists?
Thank you, Aaron, for the sharing. On hindsight, just wondering whether we would have considered an alternative route for the IABP. It is in the literature been described, going from axillary artery or even subclavian artery. I've done it once under an emergency situation. It does work. It's just to remember that it's an opposite direction. Something to think about.
Yes, but to be honest, in our center, we don't have experience using alternative route actually. Yeah. So yeah, it's a good option. Yeah, but we did consult the cardiothoracic surgeon, and they reassured us that it's fine, it's stable. But to be honest, I think this patient do have myocardial aneurysm because blood cultures is positive. And
yes, can I add a comment on this presentation? As well, I learned a lot from your nightmare case. Actually, in this situation, I dare not to put the IBB in this for this patient. But thinking about we do the PCI without any mechanical support. For example, we can go from the transradial intervention. Is this okay? You think that we have to have the mechanical cardiac support in order to do the procedure?
Yeah, I think in this case it's on triple inotrope. Blood pressure is still very borderline. So I would, if I just want to do PCI, I could have done from the femoral because I sort of not so complicated. Yeah, I finished the procedures without any problem. It's the IBP that causing the problem. So in this case, I would, if it happens again, I probably would still need support for this patient. Yeah, I would still think that it needs support. Although in literature it says that routine putting in IBP in cardiogenic patient is class 3 indication, but I think each individual is different. Yeah, that's my thing.
Yeah, thank you, Aaron, for sharing a great case. I think it's a very rare complications of IBP. So I do agree that IBP now, based on the recommendation, is low. It's not recommended anymore, but I think for us, especially in Vietnam, yes, IBP is almost the only support that we can get. ECMO is there, but very complicated, and then in most of the cases, we need another team to support us to do the ECMO. So I think IBP is still there, and then we still see the benefit. So just a question, what's the idea of doing your PCI from the left side, not but in the right side?
Yeah, because when I do the diagnostic, the wire is already crossed the aneurysm. Yeah, so I'm very sure that that wire is crossing the aneurysm. So that is why I put the IBP with the right side. Yeah, so I think it's fine if we do the left side. It made no difference. I just feel that more comfortable because I know that route is definitely crossed the aneurysm already. Yeah. And remember, the guidelines say routine IBP is class 3. Okay, so still selective patients you still can use. Yeah.
Thank you, Aaron, for sharing his case. Very educational. So yes, I mean, because of the support of the balloon pump is not much. I was just thinking in my head, if I had to face these circumstances, number one, I probably won't use balloon pump, maybe, if I had to say. But number two, I mean, so for me, this learning point is that if I do use a balloon pump, maybe take an image to see where is the wire. So maybe that's my learning point. If I really want to use, because I don't use balloon pump anymore nowadays. My balloon pump used probably one in the last 4 years.
Yeah. So I probably should have, because I did it first time, the wire went up to the correct position. I thought the second time should be correct. So I pushed the IBP forward, but I haven't inflated yet because the wire hasn't gone through the arch. I use the arch as a landmark to where to position the IBP. So I probably should have not pushed the IBP in before the wire reached the arch. Yeah, that's probably one lesson to learn. I think the first time was correct, doesn't mean the second time is correct as well. Yeah.
Thank you, Aaron. Yes.
I am wondering whether should we exchange a stiffer guide wire to a diagnostic catheter.
Chỉ còn 2 phút trình bày.
Stiffer wire for the IABP or
yes, for the IABP.
Yeah.
With the standard guide wire during the PCI, we just put a diagnostic catheter and then exchange for a stiffer guide wire.
Yeah, unfortunately, the IABP won't allow stiffer wire. The IABP come with the very soft wire. Yeah.
No, I mean that we just exchange the guide wire through a diagnostic catheter. Catheter, it will be safer when we go through the aneurysm.
I don't understand. So because I need to put the IBP in, so IBP have to go through this soft wire. So I need to put the soft wire in order to put the IBP, you see. So, yeah.
Well, probably it means we use a better wire, workhorse wire first, and then trench with.
Okay, correct. I got what you mean. Yeah, it's correct. Yeah. So you put a workhorse wire, the 035 wire in, put a diagnostic catheter in, and put a IBP wire in. Yep, I got your point. Yeah, but the thing is, I did it correctly the first time. So there's a sort of wrong assumption that you assume that the second time will be correct as well.
Yeah, thank you, Aaron. Thanks for the comments from panelists. So the next case will be presented by Dr. Liew. He have to travel very far from Kota Kinabalu, from Malaysia, to this city. So Dr. Liew, please.
Good afternoon, everyone. Thank you very much for your kind invitation to be part of this meeting and the opportunity to visit this beautiful city. Okay, I'm going to share my story of a nightmare and unforgettable challenges. I call it so near yet so far, just like how I come all the way here. Okay, first episode of the story. One fine day, sometime in December last year, in a land not so far away, you can see the map. I'm actually quite close to Thuong, Thuy Ho, is that right? Yes. 47-year-old man who has a history of hypertension and smoking. He came here with chest pain, and he has an inferior STEMI with a posterior extension. He was hemodynamically stable, and there was no heart block, but we activate the primary PCI protocol, brought into the cath lab. And this is what we find. He has a proximal RCA, which is occluded. The left coronary is also diseased. The circumflex has a proximal disease, but not dominant. And the LAD is occluded, is a CTO. Surprisingly, the patient was relatively stable. The patient actually has a fairly uneventful procedure. We crossed it with a wire, and then we did a balloon angioplasty to improve the flow. And then we proceed to treat this with drug-coated balloon. So we had 2 drug-coated balloons here, as you can see, for the mid and the proximal RCA. Patient was tolerant with the pre-dilatation, and he was reasonably hemodynamically stable, even he had a TME01 flow. That's why I was a bit brave to do this case with DCB. Anyway, he's pain-free, his SD resolved, and he was discharged 5 days later. So first episode, the end of the nightmare. He came back 6 months later as part of a plan for the stage PCI for his other vessel. He's back to work. He's also back to smoking. He has some chest pain. His ejection fraction show impaired of 45%, and he has hypokinesia of the LAD territory. So it justified for us to do a LAD in a young man. The LAD is a prognostic vessel. And we had the chance to relook at the right. Fortunately, the right looks good. After 6 months, the vessel has heal fairly well and no restenosis and some posterior remodeling. Then the left, and that was the diagnostic left that we saw, and AP cranial view shows a very tortuous LAD proximal segment with stenosis, and the mid segment is occluded. Okay, so this is just another view, the REO cranial view, and I give you a still frame to have a good look at this lesion. Okay, so several small diagonals there as well, and septal branches. And this is from the spider view, showing the left main, angulation from the ostium towards the osteo, the LAD, and a sort of a loop in the proximal LAD. So it's a very, very tortuous vessel. And the first attempt was to do this. We stuck to the 6 French approach using a transradial guide, the EBU 3.5, and fairly standard, a microcatheter, the fine cross, and attempt with the first wire, the Fielder XTR. And you can see the wire here going through those loops, the proximal, and reaching somewhere the mid, and going through the proximal cap of the CTO. Then the microcatheter cannot advance very well. And it took a fair bit of time. And you can see here we have managed to make a bit of progress, but the challenge here is it's really no man's land. This is not a straight course. We're not sure what is the rest of the LAD look like. Is it going to go back, is it going to make another loop, come back to 3 o'clock position, or is it going to go straight down to 6 o'clock? Really not sure. Anyway, with a bit of push and pull, and we managed to advance a bit more of the fine cross microcatheter and get the wire a little bit further. And at this point, we realize this vessel is very tortuous. Very, very tortuous. And you can see the wire going up there, and I'm going to zoom in for you. And those of you who have very good eyes, you probably will see that wire might have gone to some small branch. Okay, so you had to make a turn to come back down to 4, 5 o'clock position. So we have to try to do that. I tried a different wire, a softer wire, so that we don't risk a perforation. Managed to track the microcatheter a little bit more deeper, and we actually remove the wire and do a gentle aspiration, because at this point, just checking. Who knows? By luck, we might have crossed the CTO. And we do a gentle aspiration just to see if we can get blood, which we did. And we do a careful selective injection, as shown here. So here's a small injection. We can see, okay, there's still some disease, but at least we are still the true lumen. We're able to see further down, more loops, more tortuosity ahead. Okay. So anyway, I thought, let's try to vasodilate this. We deliver intracoronary nicardipine and the nitroglycerin and repeat the angiography. And it did improve a bit of the flow and reveal what's down the LAD. So we got a few more loops to go. Okay. And at this point, it's become very challenging to advance the microcatheter and the wire. So I actually repositioned the Pilot 50 to the circumflex to give a bit more support to the guiding catheter, and use another wire. And I actually used a BMW because I thought the rest of the vessel is not the CTO anymore, so we could use a wire, and it was okay. So we got a BMW wire and able to advance it through those loops again. Then, this is the challenge. Something didn't feel quite right. Okay? When we try to push the microcatheter, it won't advance. When we try to pull it, we felt that you can pull it, but the tip is not moving. It's like you felt that it's stretching. Okay? So this way we suspect we might have broken or fractured the fine cross. So we carefully pull back under fluoroscopy so that we don't lose the guide wire position. Unfortunately, in the excitement of the time, which is often the case in all these complications, we forgot to cine and save the fluoro, okay? So I can only describe to you. So the fine cross is still within the LAD, And while we pull the fine cross back, you can remember, as we keep coming back, we keep fluoroscopy so that we don't lose the wire position. Then the proximal hub reaches near the end of the external end of the guide wire. Okay? You all know what I'm talking about, eh? Then we attach the indiflator. Okay, we attach the indiflator and then apply pressure. So under fluoroscopy, then gently as we inflate, the fine cross tip starting to move backwards, starting to come out. Okay, so the moment it entered the guide, we stop there. Because we really don't know at this moment in time, where is the fracture. So as long as once the tip comes back to the guide, exposing a short segment of the wire, we go in with a trap balloon. So we went in with a trap balloon, a 2020, and trapped the wire near the guiding tip. I wish I saved all that. In the excitement, we just don't save things, you know, always the case. Anyway, then we were safe. We trapped the wire, and then we just, under fluoroscopy, pull the rest of the microcatheter out. And this is what we show you. So it's true, we broke it. So the outer layer of the microcatheter is broke, somewhere around 6 inches or so from the tip. And we managed to remove it en bloc. We managed to examine the whole thing, nothing left behind, the tip all the way. I'm going to zoom in and show you this. So the good thing about having nowadays a good camera, you can zoom in, you can do a video. So the plastic bit is the microcatheter hydrophilic coating. And it has broke. And it has broke in 2 places. You saw that? There's a small segment there, there's a long segment there. And what is exposed there is the inner coil, which is the bit which is flexible. It's very flexible. See how flexible it is. But not flexible, we have to go through the very tortuous LED. Okay? So you get a chance to see what this fine cross microcatheter look like. Okay, here it is. So the bit that has broke is the segment which is the distal hydrophilic coating. Okay? Anyway, so continue, huh? So now we use a corset, okay? So which of course is a slightly different microcatheter design with the very, very fine braided support. So hopefully better support and hopefully won't break so easily. And it did work. We managed to get this microcatheter using again the trap balloon, trapping the wire, get the microcatheter down and advance it as far as we can go, as you can see here. Then we maneuver with a lot of patience. By now, we are already about 2 hours, and we managed to get the wire further. And yeah, we managed to get it further. So there was a switching between a few wires. We had the BMW. At some point, we switched to the pilot, occasionally the filter. I'm very careful with the filter, okay? The one that crossed you eventually was actually the BMW. The corset microcatheter was able to advance fairly deep. Yeah? Now, you notice something? Where are the tortuous bends? They're all straightened up. Yeah? And my fellow was asking, are we sure we're in the vessel? Have we perforated? Okay? So anyway, we thought, okay, just in case. Okay, so we said, okay, let's just do a selective injection. Take out the wire, aspirate. Okay, we got blood, that's good. Let's do injection. So we do that. Yeah, good. We have contrast in the distal, so we are in the vessel. Okay, so we just have straightened out that very tortuous vessel. Okay, then what do we do next? Well, we do ballooning. So here is the initial view. After we remove the microcatheter, there was some TIMI-1 flow, and we proceed to do balloon dilatation. We used that same balloon that we used for trapping. Surprisingly, it managed to go down, and we did balloon dilatation from the distal to the mid, up to the proximal. So it was after the first round of balloon dilatation. So recoil, dissection, something else. What should we do? So we thought, okay, let's just do it again. We go back in. This time we do a balloon dilatation, but we do it a little bit longer. So for each inflation, we keep the balloon inflated for about 2 minutes, something which I often do when I try to do a CTO. So that's what you see here. Okay. Actually, it's the other way around. Huh? We started from the distal, then the mid, and then the proximal. And we also use a larger balloon, okay? We use a 2.0, then we step up to a 3.0 for the proximal segment. And this is the result after the balloon dilatation. Happy, guys? We should put a vote. Who said that is good enough? Good enough for DCB? Good enough for stents? Okay. So I thought it was good enough for DCB. I said, okay, that's okay. Minimal dissection, minimal recoil. Let's just put DCB. Okay, so we put DCB. So here you are, the 2.035, and followed by a 3.030. Okay? And this is the result after the DCB. Okay? How does it look? Is it acceptable? By the consensus statement? More than 50% recoil, dissection. Look at the LAD distal. The flow is not TIMI3. It didn't get all the way to the distal. Okay? Anyway, what do? We decided to take a brave decision. Okay, take a shot with the wire. We pull back. Again, there was a fluoroscopy. I pull back the wire, leaving the soft bit of the wire in the most tortuous segment. Yeah, and take a shot. And what I was trying to show is, it was the accordion effect. Okay, that I was confident, I take out the wire, then I do a proper injection. So this is what we see. So that was with the wire on the left side, and this is without the wire on the right side. So it was a accordion effect. Okay, and this is what the native LAD looked like. 1 bend, 2 bend, 3 bend, 4 bend, 5 bend, 6 bend, 7 bends, many bends. So we thought, that's okay. The patient was all right. And anyway, if you get restenosis, we're going to bring him back to do another round of PCI. So that's the result before procedure and after procedure. So we ended there. So a few lessons learned here. Microcatheter entrapment. So over-talking is the commonest reason. Some of the coil microcatheter with the tapered tip has a potential for tip detachment. Not in this case. It broke in the shaft of the microcatheter. High-risk lesions like calcified lesions, especially they are very thin, very tortuous collateral channels. In retrograde CTO, those of you who do this, you also know sometimes we have this 2 microcatheter over the externalized wire, and the interlocking sometimes may cause entrapment. Sometimes, as we do retrograde coming out from the RCA septum to the LAD with the LAD stent, we may also trap the tip. So these are situations, be careful. The microcatheter manipulation without a wire, so people have done it, is also very dangerous. It can deform and cause entrapment and dissection. So how to take it out? I think there are pulling technique, trapping balloon technique, staring technique. People have even tried telescoping technique. In this case, we showcase a combination of technique. So from this case, the CTO lesion, extremely tortuous, adds to the complexity. The microcatheter provides support and facilitates guide wire crossing and exchanges of guide wires. The risk of microcatheter entrapment in some way is anticipated and fractured because overzealous talking. In this case, the fracture of the distal hydrophilic coating, not the tip, but it was successfully retrieved using a combination of what we call the Nanto technique, using the deflator, as well as the balloon trapping technique. And last but not least, the accordion effect is something that we need to be aware of. The tortuous artery is straightened by the guide wire, giving the impression of pseudostenosis. And during the PCI, it may mimic dissection and spasm and recoil. And I showcase something controversial, using DCB for an acute as well as a chronic occlusion. My norm, something I will share more tomorrow. If I feel the patient is relatively stable and I think the lesion can be prepared reasonably well, I do use DCB more or less as my default, unless I'm unstable patient. So not too far, not too near. Where I'm from is here on the Borneo Island, Kota Kinabalu. I had to fly to KL 2.5 hours, and then I had to go from KL to Ho Chi Minh City another 2 hours or so. Then from Ho Chi Minh City to Thuy Hoa, 1 hour or so. I wish someday we can do this. I can fly direct, and you are welcome to come and visit me. I think if I fly directly, I just take 2 hours, just in time to do one city. So hopefully I can invite some of you to visit my home, the town of Kota Kinabalu. Thank you very much.
Yes, thank you very much for the very interesting presentation about the CDO with very tortuous LED. So I had a comment on this before other member on this panel and chairperson give the comment. So for the last picture that you're not sure that you got a lot of dissection, so you slowly pulling down the wire.
Yeah.
So in this situation, when I am thinking about the sewer wire, so instead you take out everything, you use the sewer wire.
Very soft wire.
Yes, very soft wire. Keep that and see how. Okay, if the dissection very severe, so we go back to with the microcatheter, and then we do some, for example, 1 or 2 stents at the most dissected area, and then we left, and the rest of the vessel we can do the DB.
Yeah.
That's my comment, and I think
that's right. So that would be the plan B.
Yes, yes, yeah. And panel, any comment for this presentation, Dr. Lam?
Okay, thank you, Dr. Liew. I think this is a very challenging case. So for mechanism of fracture of the 5-course NT, what do you think about the cause? What is the cause of such a fracture on the microcatheter?
Yeah, I think it's over torquing. So when the catheter is trapped, the tip is trapped and unable to proceed, and then when we were torquing it on the top end, we must be causing a lot of strain on the plastic. So the microcatheter, the hydrophilic coating, eventually gave way. And it gave way in 2 places. You saw that, yeah? A clean cut break. Yeah. Fortunately, within the core, there is the metal coil, so that bit did not break. I don't think that was easy to break. So it broke, the micro, it broke the hydrophilic coating.
So why don't you use, for example, Corsair XS or Mumbai Fax, something before?
I'll be honest with you. My first choice of microcatheter often is fine cross, cost reason. But on hindsight, in the future, if I have a case like this, I'll get the Corsair out.
Okay, I have one question for you. In the complex or long or diffuse lesion disease, the role of the IVI is very important. But in this case, very tortuous lesion and long. How about the role of the IVI? Because when we use OCT, it has an accordion concertina effect. So how about the role of IVI in this case?
I have to ask you, what is IVI?
Intravascular imaging.
Ah, okay. I think, IVUS catheters is not easy to pass. Don't forget, it's a CTO and it's tortuous. And I think if you have the concertina effect, and as you do a IVUS, you may not necessarily able to tell the difference either. Yeah? So I'm not sure whether the intravascular imaging per se, be able to tell whether this is actually a accordion effect or it is a, stenosis or dissection. Some of you, anyone you have experience with that?
Yeah, I think in this case, first of all, IVUS may not go down.
Yeah.
Secondly, because of the pseudo lesion thing, it will not give you an accurate thing. We were just discussing, looking at the artery's appearance, so tortuous. Could all this lesion be spontaneous coronary artery dissection? Because SCAT, because patient with SCAT, usually the arteries are very tortuous. I think here whether this patient is a female or male.
He's a gentleman. He's 47, but hypertensive.
Still can happen in a male. So because the circ also looks like there is a lesion there.
That's right.
And the LAD is like, so tortuous. Just wondering whether it could be a SCAT.
Okay. Good thought.
interesting case, but I think its time is over for this presentation. So thank you very much for your presentation. So I think at your invitation, one day we will come to your hometown
thank you very much, everyone.
To draw with you. Okay, so next presentation is the presentation from Dr. Fazir Omar from Malaysia. Dr. Omar, please.
Hello, good afternoon. Thank you very much. So I'm going to talk today about a case. Well, this is from some of the slides are from Asia PCR. So it's a cath lab nightmare series. So there's a few cases here, and it's mostly learning process. So it's about managing complications for perforations. How do you change that? Okay, so the disclosure was this case is sort of in many years, so from 2010, there's a series of nightmares. Some nightmares are not so bad, some nightmares are even worse. And it's a shared cases from mine and also my colleagues. So I think perforation, it happens, and it's always a nightmare when it happens. You get quite scared. So I think the cases we shared earlier was fantastic by one of your colleagues from Hanoi. Number one is you recognize early. You have to recognize early, and that prevents you. So sometimes even perforation, you don't need to do pericardiocentesis because you recognize early. And I think it's very important that you need to inject via microcatheter sometimes to visualize the perforation. Immediately you inflate the balloon to occlude, and you get another access, get a friend to help you. If it's compromised, pericardiocentesis, get a surgeon, and reverse the anticoagulation. We never do, but I've done once, and that's my case number 5. So when you have a large vessel perforation, it's important that sometimes where the perforations are is not where the entry point is. So if you put a balloon here, it will not occlude. And you have to put a balloon here, then eventually over 5 minutes, sometimes you're lucky, it will seal off by itself. And how you treat the distal distal vessels are quite tricky. You need to find it, you embolize it, and sometimes you can put a covered stent if it's a very distal of a perforated branch origin. So this is case number 1. It's a CTO of the LAD. Actually, simple CTO, soft wire only, not even a CTO wire. Post-stenting, there was some, where was this things? There was some haziness distal here, so I was not sure. And I don't like to come back to work at night because I want to sleep, so I tend to sort it out usually quite early. So I injected the microcatheter distally, and further down you don't see anything. And then as you bring up, and then you can see some form of flow here. And when we did the echo, there was some rim of pericardial effusion. So usually if this is going to be a problem, it might come back in about 5 to 6 hours time later, or it may seal off by itself. Sometimes it seals off, sometimes it doesn't seal off. In this case, you need to balloon. So when you balloon distally, you can see there's still a flow somewhere. And then when you do proximally, you see it occlude. So you know roughly where you want. Sometimes you see cases where they put 2 or 3 covered stents because you're not sure where is the exact location of your perforation. So this one, we put in a 2.5, 20, and then it kind of seal off, and then we're happy, and then we left it by itself. That's a mild case. So second case, a perforation. This was a few years ago, and so we did the AV fistula, LAD fistula by coiling. And then there was a short CTO attempted by our colleague, and it failed and stopped. But you can see the wire went somewhere funny. But the last shot, there was no perforation seen. So about 2 hours later, he became hypotensive. So you know it's a large vessel, quite early, hemodynamic compromise. So we brought back him to the cath lab, did the pericardiocentesis. I just want to share one case before when it went into the RV or somewhere, we use an angio seal to seal it sometimes. Anyways, if you look from the angio catheter, you don't see any obvious perforation, but because he had a tamponade, you have to look for it, and when you visualize with the microcatheter, you can see, there is quite a large perforation. So sometimes you don't see the perforation, sometimes the blood pressure is low, you don't see it very well, sometimes it's very distal, you don't see it also. So in this case, we took some fat,
you dip the fat in contrast so that you know where the fat is going. Because if you don't dip in contrast, sometimes you don't know where the fat is gone and you know which vessel it's gone to. So because it was a CTO LED, we push the fat with wire, or you can inject with contrast, and later on it's sealed. So this one, it got better with the pericardiocentesis. So you take the fat usually from the thigh area, you dip in contrast, and you push it either with a wire or you can inject contrast to it. And then 1 month later, we went and, because it's a fat, and I'm not sure where the fat went exactly, but we crossed the CTO. So don't call the LAD. So the plan for this is either you go anterograde or retrograde. And this case, we embolize with the fat, and then we cross the CTO 1 month later. So when they're unstable, you do pericardiocentesis. You need to recognize perforation, and there are ways to do it. So you can coil it, you can use an autologous fat, or some other devices that they use that we don't have, and also to cross back the CTO. So another learning point here is that if you have a pericardial effusion or tamponade, so you look hard for coronary perforation, because sometimes it may not be visible, and you need a microcatheter to confirm the site of the perforation. Number 3 case. This is the next 2 cases are CTO of a distal wire, and sometimes it's not so obvious. This was an occluded stent, and I think, so this was the final shot, but you can see some haziness distally, so always be careful. Sometimes you may not appreciate it. Sometimes you feel that you're very careful with your distal CTO wires, and even soft wires can perforate, especially when it's a little branch. In recovery, he became unstable, not very well seen during the angiogram shot, but as you can see from the microcatheter, it's very visible. There is a distal wire perforation. Okay, so again, you have to look very hard to find where the perforation is coming from, and then you coil it, and sometimes in this case we even put a covered stent just to make sure, because it was very small branch, we couldn't get the call very much there. Okay, case 4, again, this is also one of the branch of the RCA, so a severe stenosis appear maybe quite straightforward, ballooning, and then this was the final results. Again, some haziness, distal here, maybe, possibly. Again, and because these 10 small branches, so because we used to work, we used to work in IGN many years ago, and you know, we used to work from like 7 in the morning till 2 in the morning, and you know, the worst thing is that when you go to bed at 2 in the morning, at 3 in the morning, they call you back and say the BP becomes unstable. So this guy, 3 in the morning, becomes unstable, did an echo, he had a tamponade, put a pericardial, a chest, a pigtail there. And then again, visualization by a microcatheter is very important. So, because I've seen cases where they say, oh, they've got tamponade, but they can't find where is the perforation. It's not true, because you have to really find, and if you are the operator, you will tend to know where the wire is going, so you just have to look very hard, because if you don't deal with it, it will keep continuing. So you find the source of the perforation, and usually distal wire or distal PD, PL, I think you can safely put in a coiling down there. And this is the last case, case number 5. It's an interesting case. She's a 73-year-old lady. I remember her case very well because she had a lot of angina symptoms, you know, chest pains, and she's diabetic with CKD. So this is her coronary arteries, and very calcified. Even the microcatheter would not be able to take this bend. So it was very calcified, it's very severe stenosis, so can't balloon it, so had to rotor. So 1.25 burr, this is a rotor, normal rotor floppy wire. So you try to rotor gently, you take the bend slowly, 1 bend, 2nd bend, and 3rd bend, if possible. So, you know, trying. Yeah. So when this happened, So the next shot will be terrible. You know, so this is the next shot here. Yeah. And you can see the wire also came out. I mean, it's like, this is a horrible case. Yeah. So what do you do in this case? So you don't have a wire there because it's so angulated, you are not able to wire. So probably what you can do in this case is just wire as proximal as you can, or as proximal or as close to you can to the perforation, and just balloon there long enough, and call the surgeon. You know, so that's very important. So once it's flipped, you know you're in trouble. So this was a case we just wired down. I don't know where the wire went. We gave half dose protamine here. So this is the only case ever in our life that I gave protamine to reverse while the device is still there. Long balloon inflation. So the next case, next step will either call the surgeon, balloon, go in, or maybe the fat emboli, like my case number 2, you emboli with the fat, you cause infarction, then you go back again, possible. Yeah. So anyway, so the next shot for her, there was slow flow in the LAD due to thrombus, maybe a long balloon inflation. So we accepted this case. Yeah. So anyway, we went back to ICU to see her the next day. I remember she said, "Oh, doctor, thank you. I have no more chest pains." So we've infarcted the LAD, and she's treated by infarcting of her LAD. So pre-PCI, her LAD is good. Post-PCI, LAD is bad, but she's angina-free. So this is one of those things. So what is important is, I think, to recognize what happened. Try not to panic. And if you want to panic, you panic with your friend. So you bring a friend to panic along together with you. If you have calls, it's very good. Micro calls. I was just discussing with, about coiling, and I think coiling sometimes you need to give some time, because coiling they got some feathers there, so it does tend to thrombus, but sometimes you need a little bit of time. Micro calls are good. So make sure you have calls in your lab. If you don't have calls, and there's 2 types of call: the one that you pushable calls, and the one that there's a magnetic detachable calls. The other one is FATs, which you have quite easily. So I think FAT is something that you need to know. And don't forget to dip the FAT in contrast so that you know where the FAT is gone. So sometimes you inject the FAT, you don't know where it's gone. So that's another tip. And like the case of the ping pong CTO, is again, if you have if you want to be very cool about it, you can get another access. So as you balloon inflate, you bring the wire down, so everything is very controlled. Oh, by the way, for this case, for this lady who's got a massive perforation, we didn't even need to do any pericardiocentesis. So I think the very important part is that you recognize early, and sometimes when there's a large one, it looks very scary, but because you won't miss it, you immediately balloon it. There was no need for a pericardiocentesis. So sometimes I find that the distal wire perf is the one that sometimes can give you more problem because you're not aware. They go back to the ward and suddenly it becomes very hypotensive. So coil versus fat embolization. So fat, you need to dip in contrast to see where it's going to go. Coiling, you can see very well. Coiling, you have a controlled delivery. Sometimes you need a larger microcatheter. Fat, you can use any fine cross that you are used to. So fat, so you try to put it up there, push it in, and either you use the soft wire to push it all the way down, or you can just contrast and inject it. Okay, so my last 2 slides here. How to prevent rotor complications. You take a burr to artery ratio of 0.5 to 0.6, a smaller burr. Use a speed about 140 to 150, so not too fast. A gradual movement, so do not push it so much. So in my last case of number 5, if I have to do a very angulated, and probably I will use an extra support wire so that it's supportive, because it's very calcified and the angulation is actually a relative contraindication because of this very tight angulation. Short ablation, 15 to 20 seconds. Avoid decelerations, and nowadays with the Rota Pro it's easier because you don't have the pedal. You just press with you just press the button there, and you do a final polishing run. And sometimes if I want to make sure to get the rotor slightly larger lumen, I will use a shorter rotational speed at 120, 130, final run, to have a slightly larger arc of atherectomy. So for the case 1, if you have a perforation, you can use a covered stent, but just make sure where your balloon placements are so that you don't have to put 2 or 3 covered stents. Number 2, you have the choice of fat emboli. Number 3, you can use coil and even a covered stent when it's a branch. Number 4, a case of coiling. And number 5 is a prolonged balloon tamponading the artery and forming thrombus. But like I said, that was the only time we ever use a protamine in a perforation because it's too dangerous. Sometimes you will find thrombus going to the other vessel and you can get into very big trouble. So I wouldn't recommend it to use protamine. So ensure that you have, when you do all these complex cases, and sometimes it's not even complex, sometimes even, you know, like you say, simple cases you have problems. So you make sure you have bailout devices such as covered stents and coils. Watch your wire. So the case number 1 was actually a soft wire that went into a diagonal branch and somehow there's a distal wire perf. Do not ignore distal wire perforations. So you take time to assess, and if you don't want to treat it, you can do repeat echocardiograms. And I've seen sometimes distal wire perf, they don't treat it. Once the devices are all out, you can give protamine to reverse it quickly. Sometimes it helps. If in doubt, and if you have if you think there's a perforation and there's a pericardial effusion or tamponade, use a microcatheter to assess the perforation, and know your perforation algorithm. And the last slide is that sometimes when you do complex, you need to plan well. So know your lesions, know your equipment, and also know yourself. Okay, thank you very much.
Yeah, thank you very much, Dr. Fazir Omar. Give us a lot of learning point, and I would like to ask the panelists and give a comment for this presentation. Dr. Lam Ho, please. Do you have any comment?
Dr. Omar, thank you. Very nice sharing. It demonstrates all the techniques for wire perforation, distal perforation, something like this. Recently, I tried some new idea, is to use the wire coat, the suture wire, the wire coat to replace fat and use it for distal emboli to seal off the distal perforation. I found it could be very effective and easy to use.
So you use a suture so that you can see the fat also better as well for visualization and also to create thrombus.
It's not visible, but it's easily available because you always have absorbable wire. You just cut it into small pieces and then you can go for seal. Just use it, just use the material for emboli.
So you wrap it around the fat, the suture?
No. Just a piece of small pieces of wire coat. Okay. No additional comment. I think most of the cases like this, for distal wire perforation, most of the time it won't have much problem unless you miss it. Many of the time the problem it happens as the case you saw. The major trouble happens is you miss it and then you discharge into CCU. Few hours later, tamponade.
Xin thông báo cáo viên chỉ còn 2 phút trình bày. Xin cảm ơn.
Otherwise, most of distal perforation can be managed effectively and quickly.
Yeah, the suture I have used as well. I just cut short lengths of Vicryl and just push it down the microcatheter and inject and flush it down. You can't see it, but you know by seeing whether there is a perforation or it has stopped bleeding. It's not really opaque, the sutures. Yeah. The other thing I was talking to Dr. Hui here was the first case when you showed there was a little bit of blush and wondering whether it was perforation. It's quite tricky. The other differentials that we sometimes have to think about is the Thebesian vessels. And especially in the CTO, we have no clue until we cross. But the clue is, of course, whether our wire was there. Because sometimes they are in a small side branch and you knew your wire never was there. So that's when you had to suspect whether it's just a small Thebesian vessels. But if it's not a CTO, go back and look at the diagnostic again, and sometimes you see it's already there. I have 1 or 2 cases like that, and I actually waited for 1 hour on the table, just to be sure it is not a bleeding. Okay?
Yeah, that's true. I mean, sometimes you see that from CTO. The first case was the annoying part. There was a small rim of effusion, and then you're like, you know, yeah, it's just so annoying.
Dr. Omar, can I ask you maybe the last question, and the chairperson will give the conclusion. And with the complication of the router, the case with the router later, so do you think that we can, in some situation, for example, Dr. Thuong also has some experience about, and I also, that we do the router plate for the proximal end, proximal segment, and then if the distal very angulated or very tortuous, so we keep that and we use the scoring balloon or complex or something like that in order to deal with the calcification. Otherwise, we have to cope with the very dangerous complication like this. So I think that also a good solution in some situation.
Yeah.
What do you think?
Yeah, I share your idea. I mean, hopefully the score flex can go down. But yeah, I think that maybe you prepare the proximal vessel very nicely, cutting after that, and then try. Sometimes it helps. Yeah.
Thank you very much. To conclude, I would like to thank all presenters for your very educational presentations. Before going to the next session, we will take a break of 5 minutes, okay?